We are honored to present the OPSI Frank Dono Best Practice Award this year to three organizations. The OPSI Award is named in honor of Frank Dono, who was a longtime leader and pioneer in patient safety and equality. Throughout his 50 years in healthcare as a healthcare professional, Dr. Dono was a pioneer in the cause of patient safety long before it became the thing. And his leadership was instrumental in developing a strong patient safety standards and practices in healthcare. He was passionate about patient safety, not only in the hospital setting, but across the continuum of care. He had been one of the key OPSI board members since its inception and contributed to helping the organization with many successful projects. OPSI will open the application for the 2020 OPSI Best Practice Award in September, and it will be open until December. Now I'd like to honor to present the OPSI Best Practice Award. The OPSI Best Practice Award is the annual award that recognizes a program that demonstrated a focus on improving patient safety in the healthcare setting by incorporating regional and national patient safety benchmarks, as well as remaining unique in the healthcare, Ohio healthcare market. The Ohio Patient Safety Institute recognizes three distinct best practice awards this year: one for acute care, one for primary care, and our first patient engagement award this year. Would the representatives from Cleveland Clinic, Nationwide Children's, and Cleveland Clinic Fairview Hospital please come to the stage while I'm introducing everyone else. The durable healthcare discharges require a hardwired, standardized transition. The hospital wanted to make such a solid transition from the hospital to a reality for their patients, thus created a discharge checklist project, which was implemented for inpatient discharges in the hospital. The goal of the project was to obtain 100% completion of all discharge medication reconciliations and discharge summaries prior to the patient leaving the hospital. The results of the project showed great change in the discharge medication reconciliation it got near 100% completion before the patient was discharged. And it also resulted in a change in patient best practice standard by completing the discharge summary in real time that can travel with the patient to the next level of care. I am pleased to announce that the Cleveland Clinic will receive the OPSI Acute Care Best Practice Award for Discharge Checklists this year.
Thank you for this kind honor. Matt Hogan and myself, Amy Olin, are here from the Cleveland Clinic, and we're glad to have this honor, hoping that the discharge from a hospital is safer now today than it was last fall. And I hope to think that for all y'all, if you came to our hospital and were discharged, a great number of you would have a discharge summary completed. 100% of y'all would have a discharge summary completed at discharge, so you know what meds to take when you get home, and your primary care would know the same thing. And the story would follow you from the hospital to the post-discharge space. So we're glad to work on this, and thanks for your support.
Evidence-based practice and clinical literature suggests that assigning specific primary care physician improves continuity care, increased receipt of preventive services, reduction in emergency department visits, increased health literacy, and increased patient-provider satisfaction. The project's goal was to assign 90% or greater of their attributable pediatric patients, not only to a specific PCP, but to ensure that they have a designated patient, a medical home. The focus of the project was based around the patient and family engagement. The awardees used patient-family focus groups along with feedback during the walk-in clinic visits to understand what a medical home means to their patients. They also not only met or surpassed their goal of 90% assignment, but now are taking it one step further to improve measuring of the percent of subsequent visits following follow-ups with the same PCP. Beginning with a baseline of 6%, they have surpassed and sustained gains of 90% or greater assignments this past year. I am pleased to announce Nationwide Children's will receive the OPSI Primary Care Best Practice Award for PCP continuity of care.
Thank you. Continuity is such a big issue for primary care providers, and so it really means a lot to us to be recognized for improvement in such an important area. In our primary care network, we take care of over 85,000 patients, and so seeing improvement for a population that size really took efforts from 300 to 400 people on our primary care team, and some of them are in this room today. Most of them are not, but I want to say thank you to everyone for all their hard work on this and their contributions and for all the work they continue to do every day to improve outcomes for our patients. Thank you.
Thank you. There's a crisis in Ohio related to illicit opioid use. This project goal was to decrease opioid exposure and use in maternity patients after a cesarean section. The anesthesia and nursing teams identified an opportunity to reduce the use of opioids. Anesthesia presented the reduced opioid option or route protocol to a multidisciplinary team, which created the post-cesarean section pain order set. The protocol included implementing nursing protocol to encourage adherence to routine medication schedules and supporting non-narcotic options. Patients were educated about the negative effects of opioids and the new protocol. Nursing leadership rounds further engaged patients to ensure pain was well managed. The average morphine equivalent dose per patient within the 24 hours after C-section reduced from 19.4 MEDs pre-protocol to 6.5 MEDs. The average MED per patient was also decreased up to 120 hours post-C-section. I am pleased to announce that Cleveland Clinic Fairview Hospital will receive the OPSI Best Practice Award for the reduction of opioid use in post-C-section patients.
Well, when we started this project, we really were trying to achieve a few things. Patient safety, we wanted to protect our patients, but we also wanted to protect our community. And to do that, what we really realized is we needed systemic but also cultural change. And that's what I challenge everyone in this room to go back to your hospitals. This is not about a protocol change or a change in medications. What really happened here was ideas came together and our nurses executed. They bought into something that's very difficult, giving patients pain medicines that are non-narcotics every 3 hours, 24 hours a day. It took a lot of commitment. It gave them face time with our patients, and they were continuously educating, and that's why we see the dramatic results that we saw. And you can read about it a little bit. It was picked up by the Wall Street Journal. It was published yesterday, and it describes a little bit more about our project. But ultimately, for us to combat this opioid crisis in this country, we need to change our views as providers as well as our patients' perceptions on, what pain is after surgery, and to get them to realize that narcotics are not the best or the primary pain medicine. Thank you.
You may have to go like this, put the words up front.
Here we go, guys. Real quick. Thank you.
Thank you. Thank you so much again.
Congratulations.
Congratulations. Thank you. On behalf of the Ohio Patient Safety Institute, I ask that you please join me in congratulating all three of them, Cleveland Clinic, Nationwide Children's, and Cleveland Clinic Fairview, for their outstanding work this past year. To moderate our final panel, I am honored to welcome Chip Winslesko, Executive Planning, Director of Planning and Development of Monsecure's Mercy Health in Cincinnati, Ohio.
Thanks, Rosalie. Good afternoon, everyone. All right. Thank you. For our last session of the day, we will be focusing upon equity of care and all of the considerations that are included in aiming for true equity of care. None of the presenters for this session have disclosed any perceived or actual conflicts of interest. Now, our first presentation will cover the basics of care equity and clarify some key terms for us. Suzanne Hess is a regional coordinator with the Ohio Hospital Association's Hospital Improvement Innovation Network, or HIIN. In this role, she supports the quality improvement needs of several Ohio hospitals throughout the state. She has led numerous clinical quality initiatives in her past role as a vice president of quality with a community hospital, focusing on outcomes and care equity. Suzanne holds a Master of Business Administration degree from Ohio University and a Bachelor of Science in Nursing degree from Capital University. Please join me today in welcoming Suzanne to the podium.
They have a lovely little sign here that says, click here. I was worried I forgot to ask how to do the clicker, so hopefully I'll be just fine on that. So as Chip said, I currently work with the Ohio Hospital Association in the HIIN project, and that is Hospital Improvement Innovation Network. And I have a specific set of hospitals that I work with, and I go to those hospitals and discuss what they are doing with quality. And the goal of the HIIN is to reduce harm, all-cause harm, And it is my extreme privilege to be able to work with those hospitals and to see what they're doing, to learn from them, and then to be able to give that information back out to other hospitals. So that has been something that I've been doing for 2 years now, and I really enjoy that because from my background in quality, this gives me that ability to see it go even further as I'm working with other hospitals. So for today, the outcomes that we are hoping to provide to you is to increase your understanding of health equity, the terms and the different phrases that go with that, and also give you some components on how to address health equity. And that is going to be from my presentation as well as from my presentations from Dina and Linda as they come up. So I'm going to give you just some basic outline. I really consider my introduction or my presentation just to be a prelude to their information that they are going to be giving to you. So as you see here, I have a lot of different eyes looking back at you because I want to discuss looking at health and our health care through the lens of health equity. And as we've been looking at health equity, CMS, that is one of the different focuses that we have with the HIIN, and we're just getting started with that. And I'll talk to that a little bit later. But as we start looking at that, our conference has been about disruption. Disruption is a service or an idea that radically changes our current strategies, our current practices, and makes us start rethinking. And health equity is not a new term. It's a term that has been out there, and I haven't even given you the definition of health equity yet, but I will get to that. But it is something that we really truly need to start looking at outside of the box as to how we currently do healthcare, and we need to disrupt some of our services and the way we do business to be able to reach the goal of health equity for all patients. The other term that I wanted to use before I speak basically to the screen that you're seeing is the word flexibility. So we have to be disruptive and we have to be flexible. When I was in nursing school, that was one of the first concepts that they taught to us, that if you are going to be a nurse, you're going to have to be flexible. Flexible means that you have to be able to modify and respond to those circumstances and those changes that occur daily. Sometimes we get used to our situation, but we need to be able to be flexible and on the move, and that is healthcare. And the last term that I want to discuss is passion. So I usually consider myself not to be a very passionate person, but basically passion is powerful, compelling, emotional feeling. And over the weekend, I had a long trip by myself, and as I was driving down the road, I started thinking about my career and the patients that I've cared for through the years. And I could not believe the number of names that I could remember, the number of situations that I could remember. And I could remember the basic needs that they had at that very moment for me, but when we start talking about health equity, we have to think about those needs we're meeting right that minute and what they're going to need as they go out into the community. So now as we look at these eyes and we look at the lens of health equity through the eyes of our patients, let's talk about an African-American male, older gentleman. He's been in the hospital several times now. He's had pneumonia several times. And as the nurse is looking at his history, he still has not had a pneumococcal vaccination. So why has he not had a vaccination? Check with the patient. No, he doesn't want a vaccination. Basically, he doesn't get a lot of health care other than when he is in the hospital. So he doesn't have much of a follow-up. So there's not that opportunity to talk to him at the physician's office to give that. There's also a lack of trust of the healthcare system for this gentleman. And there's also some myths about how some vaccines can cause some additional issues. That is not uncommon within many patients, no matter what race they are, but in some races, that is an even higher concern as they are coming into the healthcare situation. So definitely this man has some healthcare issues. He has lack of access. He has some misunderstanding of healthcare. And so we are not maybe meeting his needs by not being able to address those issues. How can we address those issues? And as we go through the day, hopefully we'll address some of those so that you can take some of that information back and start working with your patients and identifying some opportunities or barriers that you may have to address. Our next patient is a patient that one of our regional coordinators worked with. She is actually a physical therapist. And she still goes out and sees patients in the home. And one day she was working with a older lady that no longer drove. She was going to need some physical therapy. And as she was doing her assessment, and I kind of found this interesting, I didn't think about a physical therapist asking about food, but part of her assessment was to ask what she ate each day. And this little lady said that she frequently ate candy bars for lunch and for dinner. And so as we've been working on health equity in our house at OHA HIIN, we've been talking about it. So it kind of clued her in, maybe I need to ask a few more questions of this lady, of this patient. And so she asked her, well, why do you eat candy bars for lunch and for dinner? And the lady's answer was that she never knows when she's going to have transportation to get to the grocery store. She's older, she no longer drives, and although there are people that can sometimes take her, it's not consistent. So based upon her age, her lack of driving, she now has barriers to her health care or to her overall health that impacts food securities and also transportation. So I hope that this gets you to thinking about the fact that meeting the health needs of our patients can be very complicated and diverse. So I've talked a lot about health equity, really didn't give you the definition, but the definition of health equity is the attainment of the highest level of health for all people. And in my examples, basically I was telling you all of the different barriers, or if you want to call them disparities, that the patient may have. Disparities can be along the line of race, ethnicity, or language. It can also be along what we call social determinants of health. Those social determinants of health can also be considered social or economic disadvantages that prevent the patient from meeting their health, highest level of health. So as we're looking at health equity and how we can achieve health equity for our patients, the first thing is to value everyone equally. Valuing them equally and treating them equally are two different things. So if we were treating the first gentleman versus our second patient, if we would give them the exact same kind of care, equal care, it may truly not be what will lead to equity of care. So we will talk more about that as we go through. And then the next part to achieving health equity is focusing on ongoing efforts to address avoidable inequalities. And that's truly our challenge today, is how we can do that and address those inequalities for our patients. As I've been out working with our hospitals, one of the things that some of the hospitals has asked me, are you talking about just for inpatient? Are you talking about for outpatient? Well, as part of the HIIN, usually we focus on the inpatient. But health equity cannot be something that resides in one setting. It has to be across the continuum. It has to be working with the different entities within your community. And I have seen wonderful examples of that. Hospitals that are now working more with their health department. Not that they didn't always work with their health department, but they're finding new ways to work with the health department because the health department is trying to address these issues for these patients also. Or they're now working more with the inpatient and the outpatient setting. How can we share information across the settings? How can this care be continued across those transitions? We've always talked about transitions of care, but now how can that impact their health equity also? So, as we have started working with our hospitals, this is not only true of Ohio, but it is true across the United States because I have worked with many wonderful other HIINs and hospitals as we are discussing how to meet the health needs of our patients, but we need to increase awareness. And at one point in time, one of the speakers was talking about, we've got the awareness, now we need to start triggering. Well, in reality, we are just starting on awareness. We have hospitals that really actually don't even know the term health equity or health disparity or social determinants of health and have not started. And that's okay. That doesn't mean that one place is better than the other. It's just that we're on a different place in our journey. So really, honestly, we are at awareness, and then the goal is for triggering. However, I will tell you there are some hospitals that have not really, in their mind, started the journey towards health equity, but they are still identifying their patients and doing things to improve their health. So as we move through, we want to increase the awareness for our hospitals, for our community, and also help identify how that spreads from one location to the next. Because some of our hospitals that are working on health equity right now, it may still not have advanced out into the whole setting of the hospital, the physician's office. Sometimes when we talk to quality, well, that is another department. But in reality, it needs to reside in every department, down to our patient level. Our caregivers, they need to understand how the decisions that they are making today or the questions that they are asking today will impact how we give care to that individual person as well as possibly a whole group or a whole population. And all of this we want to use to increase performance and outcomes and close those disparity gaps that our patients may have. So one of the things that we started with that has, I believe, really helped our hospitals to start looking at where they are in the continuum of addressing health equity was a health equity organizational assessment. And that organizational assessment has 7 components, and it starts with data collection. And sometimes you want to think, well, what does data collection have with doing with improving? Well, we all know at least from a quality point of view, you have to know the information before you can start addressing it. And I'm not going to go down through each of these right this minute because the next slide I'm going to start individually going through them. But you have to start at the basic, and then you have to advance on to that infrastructure and that culture. We talk about infrastructure and culture on many different levels. This is just that next level of seeing how we can take care of our patients at their level. And so now we'll talk about some of the different ones. So data collection. We want to start with race, ethnicity, and language. And most hospitals will immediately say, oh yes, we do that. And actually, when we looked at the health equity assessment, before we even gave it out to the hospitals, we were like, we can basically pretty much answer this question. Our patients do collect this data. But it's more than just collecting the data. Are the patients actually self-identifying themselves? Or is somebody basically looking at the patient and saying, oh, they look like this or they look like that, and giving that information? Or sometimes on the language, they can get out a few words of English, and so we automatically give them the language of English. And I'm saying that from my own experience. Joint Commission, if you're a part of Joint Commission, has been working on culture for quite a while, and a few years ago we worked for months on a lot of the different elements, and I was doing a chart audit, and I wasn't even doing the chart audit for culture, but I just happened to be looking at the language. I also happened to be looking at religion, which is also important when you want to understand your patients, because sometimes religion can impact how a person looks at their healthcare also. Every patient was English. Every patient was Protestant. Now, I came from a community that didn't have a lot of diversity, but I can tell you that that was not appropriate. So sadly, we had to go back to the drawing board and make sure that our staff understood that they were comfortable with the questions. And again, so we start out with the race, ethnicity, and language, and then we want to think about those social determinants of health, which also can be called social risk factors, or it can also be just thought of along the line of socioeconomic. So what all is in socioeconomic? It's whether or not they have those food insecurities like I already mentioned. Do they have access to care issues? Do they have transportation issues? Is there a difference along the gender line? Is there a difference along gender identity or sexual orientation lines? Is there mental health involved in that? One of the ones that I should have thought about but didn't as I was starting to learn more about health equity was incarceration. I would have never, a history of incarceration, that is definitely going to change their perspective. So there are a lot, social determinants of health is what you're born in, you live in, you work in, you worship in, that everyday environment that the person goes back to and may support or hinder that person's ability to achieve health equity. The next part is data collection training. So I had a really hard time not mixing my data collection and my training together because I want to kind of speak to them together, but I wanted to separate them so that you don't mix the two. So for our training, are our staff comfortable with asking the questions? Have we provided them the tools to understand the importance of the questions? So some hospitals or some health systems have done a very good job of that. Others, when I ask that question, they kind of look at me and, well, yeah, we train them on how to ask those questions. We tell them to fill in this box and fill in that box. But do they understand the importance of why that information needs to be collected? It may not be important right that minute, that day, but as we are working on diabetes and we're trying to figure out our outcomes on that, why is there a specific population that is having more of a problem? Is it our poverty area? Is it our age group? What is it? So all of that information starts with the very basic. So we need to train them. And sometimes, even though some of these questions seem pretty point blank, should be, you would think would be easy, there are patients and families that are uncomfortable in the healthcare setting. They don't trust the healthcare setting. So sometimes some of these questions feel like that their privacy is being invaded and they don't want to give that information. And if they don't want to give that information, that is fine. But sometimes we just need to explain to them, we need this information so that we can provide better care for you and be able to identify our patients. But sometimes staff don't have that in their wheelhouse to be able to explain that. So there is more to the training than just saying, fill in this box, help them to understand it. The other part of collection of data training is those social determinants of health. It's not just the race, ethnicity, and language. It's helping them to understand why we need to know about what their home environment is going to be. And we do ask those questions, but the part of it is where are those questions living once we ask them? And some of those are more of a narrative format, and where do we find it? Who asked the question? So helping them to know where to ask it, and then skipping back up to data collection is how are we going to determine how some of those questions are going to be asked, and where is that going to be housed, and who has responsibility for that? And then the final one on this page is data validation. So once we've trained them or we know that they're collecting that data, how accurately is that data being collected? One of our hospitals back in 2018, summer of 2018, did a presentation for us. And one of the things that they discussed during that presentation was that they had a lot of unavailable, declined, or unknown. So sometimes we don't know the answer because the patient came in and they're sick and there's nobody with them, and so they can't answer those questions. So it can be appropriate to answer unknown, unavailable. And then again, there are patients that are going to decline. But we want to make sure that these answers are not being used as a way of moving around the question if the patient, or if the registration or somebody is uncomfortable with those questions. So they did an analysis of why they, how high those answers were, and it was quite high. They have cut that over in half and now have more answers to those questions. Some hospitals have queues. If those questions aren't answered, they go back and ask those once they can do that to make sure that they're getting all that information. So data validation is important. when you start doing statistical analysis, if the majority of your charts are having unknown, unavailable, or declined, it's pretty hard to identify what your patient population is. So we have to have data collection. We want to make sure it's correct so that we can get to the point of where we're analyzing what kind of patients that we are caring for. And that analysis can come in many different forms. And it can be kind of overwhelming when you start thinking about it. But some of the ways some hospitals have roundabout ways of looking and stratifying data is with your community needs assessment. Community needs assessment's only done once every 3 years, so it's not real time, but it is still very valuable information to look at what populations need better services. But then from the day to day, lots of hospitals have what they readmission teams, you may call it something else, but they go through and look at their patients. So are you including these different elements in your analysis when you're looking at those patients that are being readmitted so that maybe you can find trends? It's our lower socioeconomic class. It's Hispanic population. It's whatever population you might identify in those trends. So that is one thing that I was still working at my hospital that I came from, that now that I've learned more about health equity, I would definitely be changing that readmission tool. One of the hospitals that has done a presentation for us said, start where you're at. Some of us have more resources than others. If you're working on diabetes, you're working on your cardiac patient population, start adding in looking at some of those elements, whether it's race, whether it's ethnicity or language, or some of those social determinants of health. Payer source can kind of help you identify if they're in that poverty level or not. Age, gender, those different elements will help you to start looking at your patient. Then once you have some of this, it doesn't have to be a big document. Today you have 2 things that you're going to share in regards to how you're looking at health equity. And you can build on it tomorrow. But are you sharing that with your board, your physicians, your nursing staff? And one that people may not think about is if you have a patient family advisory committee, take that information to them. They are a wealth of information, as many hospitals have found as we are moving through that. Then you want to work on resolving gaps. So you've identified your gap, and what are you going to do with that information? Some of our hospitals, as I talked about data stratification, they may not be able to or be at the point of stratifying their data at this point in time, but they are able to identify some of their patient population from anecdotal information. That is just as good as, well, I'm not going to say we don't still want the stratification, but it still is identifying some needs of your patient population. So there has been some great projects, some great process changes that some of the hospitals have done just with some of that anecdotal information. And then the last part is building that infrastructure. Are you educating on culture? Are you providing services for culture? Everybody provides service, or at least I think everybody provides some kind of a service line for the different languages, a language line. But like one of our hospitals, and I think that they're here today, but I won't call out their name, but due to industry in their area, they have changed some of the different patient population, and they have went from using the language line 3 times a month to multiple times a day, and they're looking at how they can incorporate it in their outpatient setting to their inpatient setting and how it can be real time. So if you're doing that multiple times a day, you need something that is just in time, that you're not waiting on. And then the other part of infrastructure is having somebody accountable to the efforts that you're leading, and form that committee, just like we formed the PFAC committees. And I'm sorry if somebody doesn't know what PFAC means. I get used to using acronyms. Patient Family Advisory Committee. That was a new concept years ago. It took a few years to build to hospitals to feel comfortable with that. But a committee to help us to start looking at that health equity lens, and maybe even include one of those patients from the Patient Advisory Committee. They can be very helpful. Oh, I clicked the wrong button here. There, thank you. Okay, so I've been talking about data analysis, and I've put a few things up here that you can start looking at. You've heard me speak about it. But race, ethnicity, language, age, gender, payer status, poverty quintile. Every hospital is not going to have the ability to look at poverty, but sometimes you can look at payer status. I included length of stay and admission discharge, but those actually are the next tier of looking at different things of how we may be impacting the care. So let's stick with just the top 6. And different facilities have different philosophies because I want to learn and do the best we can for our patients. One facility calls it real gap. So basically, anytime they're doing any kind of analysis, they look at race, ethnicity, language, and the gap stands for gender, age, and payer. Another facility that I was speaking to, they have shortened that down to race, gender, age, and payer. You know your patients, or you can start out with simple, look at a few things, and then as you're identifying, expand on from there. So one of the things that we have looked at is the sepsis diagnosis. And when we looked at that sepsis diagnosis, older patients who live in areas of higher poverty were more likely to experience postoperative sepsis. That might be due to lack of resources. It could be due to lack of, to get back to their physician, care in the home. It could even go to that transportation and or food insecurities. It can be many different things. So we will want to break that down more. But we know right off the bat that we do have a higher risk with the older population and the higher poverty. And I said older population, and that population is actually 53 to 83 when we did the analysis. So without saying my age, I might fall into that. And then patients that are being discharged to extended kind of additional home health care, extended care facilities are sometimes more likely to come back because they probably needed more services and were not as well, or sometimes even in those facilities there's additional opportunities. So I hope this gave you a little bit of an outline to start thinking about health equity. Dina is going to provide you more detail about the history and what health equity is. I was just kind of giving you an overview, and then I know that Linda is going to share some information with you in regards to social determinants of health and how they're working on that, and that concludes my presentation.
All righty, thank you, Suzanne, for that fundamental overview of terminology. Our next presentation will provide us with clear considerations for ensuring equity of care. Dr. Dina Chisholm is the Director of the Center for Innovation on Pediatric Practice and Vice President of Health Services Research at the Abigail Wexner Research Institute at Nationwide Children's Hospital here in Columbus. She also serves as Associate Professor of Pediatrics and Public Health at The Ohio State University. Dr. Chisholm's research focuses on improving health and health care for children and families with over 75 peer-reviewed publications on pediatric health services, outcomes, and disparities. Her current projects explore how health literacy, health policy, and social factors influence the health of at-risk adolescents transitioning to adulthood. She currently serves as the chair of the Ohio Commission on Minority Health, a board member for the Health Policy Institute of Ohio, and a member of the CMS Advisory Panel on Outreach and Education. Dr. Chisholm holds a Master of Science degree in Preventative Medicine and a doctorate degree in Public Health, both from The Ohio State University. Please join me this afternoon in welcoming Dr. Chisholm.
Okay. Good afternoon, and thank you for that kind introduction, and thank you for the invitation. I'm going to start off by saying that this is really a chance to give us some background about where we've come from and to put it in the context of where we are so that we can figure out how to get where we need to be. The slide says unequal treatment 15 years later. This is actually a cover slide that I used when I did this presentation, or a similar one last year, so it should actually say 16 years later, but pretend like I am. The interesting thing about starting with this concept of 15 years later is I graduated with my PhD the same year that this publication hit the streets, which was 2013. And when this publication hit the streets, Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare, it was a tectonic event. It was a tectonic event for both health care settings, health research, and a newly minted, fresh off the hood doctoral health services researcher who said, this book is the roadmap to the entire rest of my career because it says all the things that I've been thinking, but nobody was ready to say out loud. Why was this tectonic? Because the first finding that it put in its executive summary, I think it was on page 3, was racial and ethnic disparities in healthcare exist. And because they're associated with worse outcomes, in many cases, are unacceptable. This was a seminal statement of fact. Not they might, not they may, not in some situations, but a clear statement that after reviewing hundreds of articles and research and data, there was no doubt in saying that disparities in healthcare exist. This made people look, made people take this seriously, and allowed us to really build a research field in this area. But they didn't stop there. So it's great that they sort of started with this showstopper statement, but then they kept going. And their second finding was not only are there disparities in healthcare, but those exist within a broader context of lots of other disparities that are both historic and contemporary, that are social and economic, and that are evidence of persistent racial and ethnic discrimination in many sectors of American life. That's a lot of words that say something that people didn't like saying. That it's not just that there are healthcare disparities, but that those healthcare disparities are exacerbated by and exacerbate all of the other disparities that racial and ethnic populations face in their lives. But it didn't stop there. It kept going. It also recognized that this isn't just an issue of there are a few bad docs out there and in one-on-one situations, sometimes something inappropriate, sometimes something discriminatory, sometimes something racially biased happened. This was not saying that this is about individual providers and their relationships with individual patients. This was saying it's beyond that. It's multifactorial, that it involves health systems and providers, and patients, and utilization managers, and all the other players in the game that create a system that contributes to healthcare disparities. It went on to say bias, stereotyping, prejudice, and clinical uncertainty on the part of healthcare providers may contribute to racial and ethnic disparities. Now, this is where they get a little soft, they get a little wiggly. That happens. And they said, while indirect evidence from several lines of research supports this statement, a greater understanding of the prevalence and influence of these processes is needed and should be sought through research. So they were willing to say that there's probably an impact of bias and stereotyping and prejudice, but we really want a little more data before we're going to believe that. And then they also closed by saying that there are some studies that suggest that minority patients are more likely to refuse treatment, but that these do not explain the underlying differences. So in short, the big findings were healthcare disparities exist, that they matter because they impact health outcomes, that they're part of a broader set of disadvantages that minorities face, that they're multifactorial, it's not one thing that you can fix, that the elephant, the word that people don't like to say, racism, is part of the problem, but we need to do more study to understand how big and where and why, and that patient choice is not the problem and patient choice is not the solution. This started a real discussion that has led to the types of work that Suzanne started talking about and that the rest of our panel will continue talking about. We talked about at the beginning sort of what are health disparities and what is health equity. When we talk about health equity, we're really talking about the opportunity for maximizing everyone's opportunities for health. When we talk about health disparities, we're really talking about differences in health. And when we talk about health care disparities, we're talking about differences in health care that influence health. So those are three words that sometimes get tossed around in the same conversations, but really do mean different things. When this document came out talking about health care disparities, they felt a need to define what a health care disparity was. And so they came out with this figure, which raised a lot of hackles and generated a lot of discussion. Because what they said was, we accept, based on all the data we've looked at, that there is a difference in quality between non-minority and minority patients. And that difference is made up of discrimination, stereotyping, and bias, how the healthcare system operates, and clinical appropriateness and patient need. And they went on to say, we're only going to call it a disparity if it's system operations or discrimination, bias, stereotyping. If the difference is caused by differences in clinical appropriateness or differences in patient preferences, then that's not a disparity because it's the right thing to do clinically, listening to patient preferences or making decisions based on clinical appropriateness. On the face of it, that sounds reasonable. But if you dig just a little deeper, if you go underneath that, we can start asking a few other questions. Who decides about clinical appropriateness? And what is that decision based on? And we have whole bodies of evidence that show that clinicians are less likely to provide opioid pain medication to people of color compared to Caucasians. And actually less likely to provide any pain medication to racial and ethnic minorities compared to white patients. Even when there's data showing there's absolutely no difference in their pain levels. Why? Because there was a myth for years and years that minorities experience pain differently. They didn't hurt as much. They didn't feel the pain as much. That was probably in part because they were less likely to admit to pain in the healthcare setting. So you say, well, it was appropriate. We didn't give them pain meds because they said they didn't hurt, so we made the right decision. But was the correct process used to identify what that pain was, to drill down, to ask more questions, to make sure that you're doing the right things? Some people turn down healthcare because they don't trust it. Does that mean that it's okay? Or does that mean we need to do a better job of building trust? Some people don't get care because they don't want to go to specific providers because they don't feel comfortable there. So their preference is that they don't seek care. Well, maybe that not seeking care is because they were treated so badly last time they went that they would never go back. And you say, well, they chose not to come. But that's not a real choice. So I say that that last box that we call okay difference probably needs a little more nuance. A lot of that okay difference probably is also disparity. But saying all that, I was just happy that people were willing to say some of those words out loud. And as, like I said, a newly minted PhD, I thought this was groundbreaking. This is amazing. People are actually saying stuff. And then I found out later, people already said all this stuff 15 years before that. Because 30 years ago, or now 33 years ago, the Heckler Report came out. And it was the Heckler Report, A Force for Ending Health Disparities in America. And it said, just as tectonic as the statement I said Unequal Treatment said, even probably better, that despite the unprecedented explosion in scientific knowledge and the phenomenal capacity of medicine to diagnose, treat, and cure disease, Blacks, Hispanics, Native American Indians, and those of Asian Pacific Islander heritage have not benefited fully or equitably from the fruits of science or from those systems responsible for translating and using health sciences technology. So as excited as I was about something that they said 15 years ago, that got said 15 years before that. and we still weren't having those conversations. Why? I don't know exactly, because if you look at what's happened in that time frame, from the Heckler report coming out in 1986, HHS created an Office of Minority Health, which was really focused on taking what was learned in that report and turning it into change. And that translated into the Centers for Disease Control putting in an Office of Minority Health and Health Disparities, NIH putting in an Office of Minority Health, actual policy changes associated with minority health, the development of Healthy People 2010 goals around health disparities, all of that leading to the 2020 report that said the same thing, and then the 2002 report that kind of said a lot of the same thing, and then AHRQ creating an actual way of measuring this. The Agency for Healthcare Research and Quality was tasked with saying, okay, we said this 15 years ago, we put out a new report 15 years later that says the same things. What's been happening? What's going on? How do we measure a change? This is kind of a busy chart, but I love it because it tells a story really clearly. If you just look at the first bar there, and you see underneath it says total 179. So of the 179 healthcare quality measures that AHRQ assesses every year, that they're able to stratify by race, 106 showed improvement for blacks over the past 10 years. So nearly 60% of those had improvement in black population. And if you look for this patient safety subset, the patient-centered care subset, the care coordination subset, across all of them, the majority showed improvement over those 10-year period for African Americans in the US. This is a celebration slide. There's very few that were worsening, and most showed improvement. Yay, this is good stuff. But then I go to the next slide because I have to. When you look at where there were gaps, what change we saw, and again, there's only 79 measures where they had data from the 10-year period and data that could be stratified by black and white. But when you look at it, what you see is that the vast majority showed no change in the gap. So even though we're showing improvement in the absolute measure, it's one of those things where everybody says, well, you know, a rising tide lifts all boats. But if it lifts them at the same rate, you don't close the gap. You don't make a difference in the fact that some parts of our population are doing worse than others. And if you look across every one of these measures, we are doing a terrible job at closing the gap. Now you might say, well, this is like a race thing, but it's not just race. When you look at our other disparities, I just do a lot of race slides because I do a lot of research in that area. But if you look at, for example, differences in rural populations, and the yellow are things where the gap is the same, red is where the gap has gotten worse. Disparities in urban rural are actually just as concerning, and in some cases more concerning because things aren't just staying the same, they're actually getting worse over time on many quality measures. Again, this is a situation where we are seeing improvement in the absolute measures, but we are not closing the gap. And the reason is that we can't just do the same thing for everybody and think we're going to get the same result for everybody, because different populations have different needs. And that is the whole concept of the health equity movement, is to get away from doing the same thing for everybody, which was our mantra in sort of the guideline healthcare driven era, to doing the right thing for every patient, which is where we're trying to be in our equity driven area. So thinking about what that report, going back to Unequal Treatment, said, it came up with a bunch of recommendations. It came out with, I think, 60 some odd recommendations, and I'm not going to tell you all of those because they'll pull the plug on me. But they were in areas including legal, health systems, patient education, research, data collection, all these different areas. I'm going to talk on just a couple of them in the little bit of time I have, and what's working and what's not. So some things really are working. So one of the key recommendations, one of the first recommendations, is to avoid fragmentation of health plans along socioeconomics, to get to the point where more people had coverage and coverage was more standardized across people so that everybody, or more people, had access to similar levels of healthcare coverage. What we've learned in terms of our Medicaid expansion and our opportunity to purchase health care through medical exchanges, through the Accountable Care Act, we've seen that all races in the past decade have expanded their access to insurance. That's been consistent for all races, also consistent for people who were uninsured, and in particularly young adults, which was one of the big areas of lack of insurance. And when you look at this over time using a line chart, this is the kind of line chart we love, because it says we saw improvement for everybody, but we saw the most improvement in the people who had the most opportunity for improvement. Therefore, we closed the gap. Now, we didn't close it all the way, but we saw a meaningful improvement. So this is the sort of thing where we can say, yeah, that was a good recommendation that we're actually making progress on. So we get to have, a gold star for that one. There are some things that are showing promise. So there was a recommendation about supporting the use of community health workers. Many of your hospitals are probably involved in programs that use whatever term you're using, community health workers, patient navigators, promotores, to help families navigate not just the healthcare system, but the social services that allow the living status that allow you to be healthy. Ohio as a state has made some significant investments in that, particularly in the space of infant mortality, in funding infant mortality hubs that are designed to identify women at highest risk of infant mortality, linking them to community health workers who link them to supports across a number of different social factors that influence their health: education, employment, food, housing, diet, all of those things. So what we're seeing in the places where we're doing these projects is improvement, and real improvement. But what we're seeing is that they're really localized to the areas where we're doing the work. We have not done a great job yet of scaling and spreading those things statewide to maximize their input. So that counts as we're doing good, but we've got a ways to go. Some of the things need a whole lot of work. So one of the recommendations was to increase the proportion of underrepresented U.S. racial and ethnic minorities in health professions. And when you look at applications to medical school 2003 to 2016, you can see that applications have gone up across the board, but when you look at African American applicants and Hispanic applicants, they've gone up much slower and continue to lag way, way behind. And if we're not having applicants, that means we're not having acceptances, which means we're not having doctors. When you look at nurses, you see similar disparities in terms of the nursing workforce not really looking like the workforce, not looking like the population that they serve. Now, some would say, why does that matter? We need the best doctors. They don't have to look a certain way. They don't have to be a certain race or ethnicity. We should be focused on just getting the best doctors. And I agree completely that we want to get the best doctors. But I also agree that it does matter that we have diversity in the workforce. There's research that shows that patients are more honest and open when they have concordant physicians. But another real interesting fact is that when you ask trainees in medical school where they plan to practice, you ask them about the probability that they're going to practice in a underserved population. More than half of African American medical students say they plan to practice in an underserved area, compared to less than 25% of white graduates. So if we keep producing people who aren't going to work in underserved areas at a way higher rate than people who are willing to work in those areas, we just continue to exacerbate the problem of having underserved areas because we're not training the people who are actually willing to go to those areas and do that work. So until we get these things taken care of, we're not going to make the impact that we could. I say all this to say that we still have opportunity for improvement. We are making a difference, and every one of you has a story to tell about what your organization has done that's made a difference. We have no doubt about that. But what we also know is that we need to do more, and we need to do it faster if we're really going to get to where we want to be as a society and as a state. The Health Policy Institute of Ohio released its Health Value Dashboard. They do this every other year to really see what's going on with health in Ohio. Where does Ohio rank in health value? They define health value as sort of the combination between the health of our population and how much we spend. So are we spending a lot of money for a little bit of health is bad. And so if you look at Ohio, we rank 43rd in health across a whole bunch of measures, and 28th in spending, making us 46th in the country overall in terms of the value that we get for our healthcare dollar. That's not even talking about disparities. That's just talking about overall in our state. What that value deficit is generating is real, live, lost years of life. This isn't just control charts. I know there's lots of control charts and lots of posters out in these hallways, and they're great, but this isn't about control charts. This is about life. If you look at life expectancy in the state of Ohio, there are places like Shaker Heights where you can expect to live 88.6 years, and places pretty much a stone's throw from here, the Hilltop in Columbus, where you have 25 years less life expectancy. That's meaningful. And part of what's driving all of that is the fact that not just do we have disparities in healthcare, but we have disparities in life. Ohio ranks 38 in adverse childhood experiences, 35th in poverty, 38th in adult incarceration, 43rd in unemployment. So the disparities that we're seeing by race and ethnicity, by urban, rural, by other populations are all underpinned by these sorts of things that are going on in our state. The things that fix that are big, and clinical care is just part of it. There's some estimates that clinical care itself is between 10 and 20% of the explanatory factors that impact health. But when you look at how Ohio spends its money, the place where we rank the best is the amount of money we spend on access to care, even though care is not the biggest driver of health. The things that are the biggest drivers of health, like health behaviors that can be supported through public health interventions or changes in socioeconomic environment, employment, education, where we rank in the bottom half, are the bigger issues, and we spend less there. This is where our opportunity for improvement is in our investments of times, energy, and money. And I say this to say that every one of us has an opportunity to be part of moving those needles, changing those colors, impacting our hospitals, our health systems, our communities in ways that reduce those disparities, so that I'm not standing here 15 years from now with more gray hair saying, we just found out that we still haven't gotten better. I'm counting that 15 years from now, we don't have to put out one more report saying one more time how big the problem is, that the next report is saying how great our solutions have been. And I'll stop there.
Thank you, Dr. Chisholm. for your thorough presentation. As a reminder, if you have any questions for the Q&A session for our panelists, please write them down on the cards that are on your tables. I noticed that we have some OHA staff members walking around the tables and collecting them. So just a reminder to fill your questions out so that we can get them asked up here to our panelists. Our final presentation this afternoon addresses the application of social determinants of health into a hospital's commitment for care equity. Linda Chambers is Associate Vice President of ProMedica Rehabilitation Services and Social Determinants of Health Clinical Integration in Toledo, Ohio. With over 25 years of clinical practice and operational experience, Linda has extensive knowledge in program development, clinical integration, and process improvement. Since 2016, Linda has led the development and implementation of a social determinants of health screening tool for ProMedica, which is currently used in the ambulatory settings with plans to expand across acute care and employee populations. ProMedica's work surrounding hunger and food insecurity as health issues has deepened the understanding of how socioeconomic factors and health inequality plays a key role in the overall health of individuals and communities. Linda holds a Master of Business Administration degree from the University of Findlay and a Bachelor of Science in Physical Therapy degree from the University of Findlay. Please join me this afternoon in welcoming Linda.
Well, good afternoon. I'm really excited to be here. My long title does not fit on my business card or my ID badge. And really the second portion of my title was something that I feel very fortunate to have been tapped on the shoulder for. You know, we all have in our job descriptions other duties as assigned. And when my boss came to me in 2016 and said, Linda, Randy Ostra wants us to get this screening off the ground, I took it not as a challenge, but an opportunity to grow myself. And it really has been very rewarding. So just a little bit about ProMedica. I'm taking a leap here that most have heard about our work around social determinants of health, but just less than a year ago, we made an announcement that we were acquiring HCR ManorCare and integrating with them. That provides us a pretty large footprint. We went from 17,000 employees to 70,000 employees in the matter of a signature on the piece of paper. We operate 13 hospitals. We have 2,700 physicians. We operate more than 450 post-acute skilled nursing, assisted living environments across 30 states. We have an insurance arm, Paramount Insurance, that has over 600,000 covered lives. So a very large group of individuals transforming healthcare. And our Randy Ostra, our CEO and president, is very visionary and really set the stage for a sense of urgency to make change, to transform care and moving out of our clinical four walls and reaching our neighborhoods and communities to really make an impact. And to Dina's point, really making an impact on providing care for all and meeting those where they live. So together, we're going to deliver high-quality, patient-centered care and a seamless and coordinated experience, providing care in the setting that meets the patient's need, and then respecting, creating a new perspective around the social determinants of health, and really around our healthy aging population. I'm not telling this room anything new, that the number of patients 85 and older is growing exponentially. And soon, within the next 20 years, the number of seniors, and I am part of that senior, given Susan's definition, the aging population is going to outnumber the children. My slide looks a little different, but very similar to Dina's around the percentages of the factors that influence one's health and well-being. Again, 20% is how many people in here are nurses, physicians, social workers, therapists? We all in this room, look, I think most people raised their hand. We all went into our roles out of college to address the clinical care. I know in my training I had very limited education on the other impacts that social economic factors, the physical environment, and one's own health behaviors, how they influenced health and well-being. But certainly 80% of one's health and well-being is outside the clinical walls, and 50% of those factors are related to where we live, work, and play, the zip code. And to Dina's point, the zip code map across Ohio, it's startling. ProMedica is doing some amazing work. Proud to be part of that transformation, but we can't do it without everyone in this room to really make a collective impact. To Dina's point about how long this problem has been around, this is a quote out of an article that was in the Journal of American Medicine in 1993, 26 years ago. Though healthcare is an essential to health, it is a relatively weak health determinant. Again, to our point that we really need to make an impact to start addressing the gaps in our care. I'm going to go through the next slides pretty quickly because there's statistics on where we rank as a nation and then as a state. But I think we're all aware in this room where the United States falls. We have the most preventable deaths, more patients with chronic disease than any other country. We rank highest when it comes to cost and spend more per person on healthcare. And we have the lowest life expectancy when compared to other countries that spend less. Again, just another schematic on this graph that illustrates the US ranked 7th in a number of categories around quality care and access to care, although we had the highest spend per capita. I was asked to come here today and share a little bit about ProMedica's journey, and we probably broke every PowerPoint rule there is with this slide. There's a lot of information on here. I'm going to help you walk through that just a little bit, but if you start up at the top left, our work really began back in 2012, 2013 around our community health needs assessment. Really took a good hard look at that time. ProMedica was a very regional healthcare system founded in Toledo, Ohio. So we had a couple hospitals. We looked at our community health needs assessment and really came to light in that assessment that we had a significant need around childhood obesity and a need that we needed to address. So that's really where we started. Coupled with that, around the same time was the healthcare reform coming into full swing. We added a couple more hospitals in the middle of the decade there, and really went to our employees and changed our mission and our vision and values, and really made an effort to improve one's health and well-being. So with our work around obesity, we peeled back the layers, and as many of you are aware, obesity is usually not just a cause of overeating. It is a relation to hunger, and hunger as a health issue, so we took a strong stance there. We recognized that we had a number of food deserts in our geographic footprint where there was not access to healthy, nutritional food. We did not have good access to healthcare in a number of the suburbs that we were serving. And then also the infant mortality rate in Lucas County was the worst it was ever. And so we came together in 2015, 16, we started screening for hunger. We screen every patient across our ambulatory and our acute care settings, as well as end of last year screening in our skilled nursing facilities for hunger. We created a new model of healthcare, again, moving from a healthcare system to a health and well-being organization. Really took a strong stance that we are an anchor institution. Typically, anchor institutions are your meds and eds, your medical and educational facilities in locales. They don't usually pick up and leave town when the times get tough. They're there, rooted in the community. So we are a strong anchor institution. As we go across the middle of the page, really working with a lot of community partners to provide economic catalysts to our communities, working with our arts community, our local higher education institutions, and a lot of developers to develop safe and affordable housing for our community members. The middle of the slide, difficult to see, but I'll touch on it. The yellow are our food insecurity interventions, and I'll talk a little bit more about that in a minute. But really, our focus is to be a national leader in social determinants of health. We, along with the ARP, founded the Root Cause Coalition, a national company or national organization to address the health of our country. We have, and I have a slide about this in a little bit, but we also have a $50 million eBay Neighborhood Promise. And the third leg of our journey is developing the National Institute for Social Determinants of Health. And really within that institute is where my role is. One leg of that stool is clinical integration, another is community involvement, and the third is research. So a lot going on, a lot that I could talk for hours about all of the things that we're doing, but we really are hoping that we can inspire others to join us on our journey to make a difference. So as I mentioned, we had started screening in 2013 for food insecurity. Today, we are screening across 10 domains, moving from that siloed clinical focus to a health and well-being focus. We created a steering committee, physician-led. We had physician buy-in and engagement very early after our initial results around hunger were released. We're screening across these 10 domains using clinically validated tools. Lots and lots of conversation about, do we cast this wide net? We're starting to see some early indications that there are pockets and gaps where we need to really dig down and drill deep into the needs of those pockets. But we are screening these 10 domains across our ambulatory primary care offices, as well as our outpatient oncology departments. We have had internal requests from our case management, our care navigation, our insurance arm to add these screening questions to the assessments that their team members are performing. Again, trying to get to the root cause and reach those patients that are at highest risk and high cost to our community. All this talk and conversation has really led us to think, are we asking the right questions? I know that we all kind of nodded and agreed that we went into our fields of study, graduated with many of us with science degrees, focused on the clinical care, where we are fixers by trade. We want to prescribe a medication. We want to provide some education on nutrition and healthy eating. We want them to exercise more. We want to get them on an exercise regime. But we're not asking the questions on the right side of the screen, or at least we haven't been historically. We're not asking, do they have food to take with that medication that you just prescribed to that patient that clearly says take with food. We're not asking about access to their food. And to Susan's point about the elderly woman who was only eating candy bars because she didn't have transportation, we historically have not asked why they couldn't get to a provider visit. That question alone, again, could talk a little bit more about that, but due to time constraints won't. But we need to ask those questions and change our own clinical policies. I'm in the process of rewriting or revising our rehab policies around our no-show cancellation policy. How many have a no-show cancellation policy in their ambulatory space? See a lot of head shaking. If the patient 3 strikes, you're out, you don't come. But we've never really stopped to ask, why is it that they're not getting? It's not because they're non-compliant and we give them a label of non-compliance or complacency. There's usually an underlying cause. So really, again, turning it upside down and thinking about things a little differently. So here's some early results. We've screened, since we started screening for hunger using the Hunger Vital Sign, nearly 1 million food insecurity screens. We started our social determinant expanded screening in 2017. We did a single provider pilot, very labor intensive, with someone asking the patient the questions and recording them in the answers in a database. But we started that in 2017. Since that time, we've screened over, this is old data, 2018 data, over 125,000 social determinant screens. And we're also beginning to screen this year our own employees through our employee assistance program. It's a voluntary program where employees feel a need to get connected to other community resources, be it financial, be it clinical services, be it behavioral health, but we are screening our own employees. And what we've seen, and no matter what population that we're screening, that 55% of the patients that are screened have a need in at least one of those 10 domains. And nearly 40% have a need in at least 4 or more of those domains. So the need is great. What we're also asking, which was not on that symbol slide, we have a series of 6 motivational questions. So it asks the patient about locus of control. Do they feel in control of the decisions they make around their healthcare, around their personal life? It's interesting that I think there's a common misperception that patients that are underserved and in that poverty range don't want to change. That could be farther from the truth. What we're seeing is that 87% of those patients screened that have a need really are motivated to change. They just don't know where to go for the help. They don't know how to navigate the system or get through the processes, bring the right documents to complete the applications to get any of those services started. So it's been, like I said, it's been very eye-opening work. Of the 10 domains, we consistently see the top 3 ranked as financial strain, behavioral health, and then food insecurity. We've got a lot of work to do yet. We've got some great results. It's going to take ongoing education, a couple lessons learned. We needed providers out of the gate in those offices to help spur the engagement. And we also need to go back and retrain our frontline caregivers to have the conversations to offer the screening. What we're finding is there's some assumptions made that if I would present in this dress and these shoes to an office, the office staff may be less reluctant to ask me to take the survey because it may appear that I don't have any needs. And so just having some scripts and some education that we can't make assumptions and we don't want to influence our care based on our own biases. So more work to do there, but it's been good. I'm going to take a little bit of a deep dive on our hunger, on food insecurity work. Hungry people are 2.9 times more likely to be in poor health and have a chronic disease, not a surprise to this group. Newborns are 1.8 times more likely to be underweight, and that can lead to a lifetime of development and chronic conditions. Children who are between the ages of 10 and 15, it has a lasting impact on their health. In fact, children who are hungry are 4 times more likely to need professional counseling, and teens that grow up hungry are 5 times more likely to commit suicide. This was some of our statistics. 1 in 5 families in the Toledo area, in the Toledo market, are hungry. So households with children, 1 in 5 are food insecure. And this is data from 2015. You see a couple other locations in Ohio, but Toledo made the list, and not something we're proud of, but we're proud that we're finally asking the questions, having the conversation, and addressing the need. We've really taken the stance that food is medicine. So I mentioned that we're doing the hunger vital sign screening in all of our care settings. When the patient screens positive for food insecurity, the primary care physician writes a prescription for food. The patient presents to one of our 3 food clinic locations. We have 3 clinics across Metro Toledo. We provide the patient and the household 2 to 3 days worth of food that's staffed by dietitians, dietetic techs, and some volunteers to help the patients make healthy choices across all the food groups. We offer some nutritional counseling, one-on-one counseling free of charge for the patient. They can come to the food clinic once a month for 6 months. Continue to see a need, they can go back to their primary care for another prescription, but we're also in that 6-month time frame connected them to our community care team, which is made up of social workers, community health workers, and RNs who will help that patient navigate the system and connect to those other resources, because we know food is not an isolated issue. There's usually underlying cause. In our acute care areas, when a patient is screened positive for food insecurity, we do send them home with a food box. Usually it's a 1 to 2 day supply for the patient. We also connect them with social services while they're in the hospital, as well as that connection, that warm handoff to our community care team to help with the follow-up connections, and community resource guides for local food access. A couple other food insecurity programs that I'd like to mention that we're doing in ProMedica. We do have a food reclamation program. We have 2 ProMedica employees that are stationed at Hollywood Casino. So any food that is prepared but not served gets repackaged, and then we ship that, we deliver that to our feeding stations and hot food stations across the Metro Toledo area. We've reclaimed 325,000 pounds of food and served a number of patients and our community members. We have an urban farm. It's a 3-acre farm that was donated to us in our northern region. We invite community service groups, Boy Scouts, Girl Scouts, high school groups, and the like to come and help us farm, help us work in the gardens where we're growing fresh fruits and vegetables. They can take that fresh fruit and vegetable home. It's also put on our Veggie Mobile. It's a mobile market that goes to our living communities within the Adrian market to bring the farmers market concept to the place where our community members are living. So that's been a really popular food project up in the north. And then we are piloting with our HCR counterparts in the Detroit market. They have decided to send food, a 2 to 3 day supply of food home with every patient that is discharged from their skilled nursing facility. Early in the pilot, that started in May, but they're sending food home. They decided not to screen, and the rationale for that was those patients that are being discharged from the skilled nursing facility likely came from a hospital stay. They have not been home in 2 to 3 weeks, and so if they had any food in their refrigerator, it probably was spoiled or not good. They haven't been to the grocery store in that length of time, so that food box, those meal kits that are going home with them is kind of just the stopgap until either family or a service, they can get connected to a community service. Often get asked, so you're doing all these things, so what? What results have you seen? And our poster presentation out there alluded to this as well. When we looked at our Paramount patients, we looked at 4,000 patients that were screened for food insecurity. So we looked at a group that had food insecurity and did not have any intervention. Another group had food insecurity and went to the food clinic. So for those patients that went to the food clinic, we saw a reduction in emergency department utilization by 3%, a reduction in our readmission rate within that group by 53%. Those patients were utilizing their primary care more often, and we saw Paramount was most excited about the last stat on the screen, a 15% reduction in the per member per month cost for those patients that had the food intervention. So early results, we are in the process of doing another year's look at the outcomes there. Early indication is we'll have even better results to share soon. It was mentioned, I believe, in one of the other presentations about infant mortality. A lot of work. We have a dedicated team of AmeriCare workers and community health workers addressing infant mortality. I'm not going to go into a lot of the stats there. If you're doing infant mortality work, you're probably well aware of the multitude of issues that occur in the moms and those babies that are born at low birth weight. But what we do know, at least in our marketplace, matters. So this slide just really bring it back to the zip code and the life expectancy range just on where you live, work, and play. And so ProMedica is very fortunate that we had a donor, Russell Ebide. He and his family have been strong supporters of ProMedica from the clinical service aspect, but really engaged Randy Ostra in conversation many years back about creating community revitalization and neighborhood revitalization. So the Ebide family donated a $50 million 10-year commitment to neighborhood revitalization, something that we take very seriously. Mr. Ebide's mission was that we not provide a handout, but we provide a hand up. And so a lot of the focus around our Ebide neighborhood promises, as you can see, the green house on the right there, we have some job training programs. We have a financial opportunity center with financial opportunity coaches to help those clients not only get a job, but be able to manage their finances and get financially stable and on their feet. We're providing health access in that neighborhood and stable housing. As I mentioned earlier, as the anchor institution in Toledo, we're partnering with a number of developers. We had a CDFI also commit to this neighborhood revitalization project. It's the Uptown neighborhood in Toledo. Our headquarters is downtown right on the river. This Ebide neighborhood promise in Uptown Toledo is about 10 blocks from the river. And we're seeing some really good engagement of the community members in that area. We're creating that social infrastructure and capital development. Russell Ebide, part of that donation included the purchase of that building on the top left. We bought that from the city. They sold it to us for $1. It was a vacant building, had been a number of things over the course of the years, but had sat empty for about 13 years. And so the first thing that we put in there was a grocery store on the first floor, Market on the Green. The reason why we did that, a lot of health systems thought we were a little crazy. Why would a healthcare system be getting into the grocery business? But it was a food desert. There was not access to healthy, nutritious food in that neighborhood. So we went to some other community grocers, and they all agreed, yep, that's a good idea. Good luck with that. So we put together a business plan. We actually were fortunate to hire an individual who had some grocer experience. The Ebide market has been open for 4 years and gonna exceed the projections on the business plan this year and beat financial projections that were made out of the gate. So it's a 4-story building. The second floor houses our Financial Opportunity Center. You can see the chef there in the middle of the picture. We have a full-service, state-of-the-art teaching kitchen. So one of the other options that we provide to patients who are food insecure and community members alike to come into the teaching kitchen and learn how to cook on a budget. We utilize the Cooking Matters classes, the curriculum. It's a 6-week curriculum where they learn how to cook a meal for 4 on $10. They get to shop in the market and buy those ingredients to take home for their family and prepare the meal, but they also are learning that day while they're there how to prepare the meal. And then they come back and share their experiences and maybe the tweaks and twists that they've made on those recipes, but a really good engagement for our community members. I'd mentioned the housing in that Uptown neighborhood. There's a lot of vacant lots. There are a lot of vacant buildings, so a lot of our developers are coming in. We just announced this spring that we will be putting in a 100-unit housing complex, mixed income, some low housing subsidies, some market rate apartments, but really starting to develop safe housing for our community members in Toledo. I could talk for hours and hours. I just touched on a number of the programs that we're doing across ProMedica. We have engaged in a number of conversations and networking and have developed our business development and consulting around social determinants of health. So we really would welcome the conversation, the opportunity to sit down and have a more in-depth conversation about embracing that anchor mission philosophy and developing social determinants where you live and work. I appreciate your time. I know that towards the end of the day of a 3-hour conference, it's not always easy to be the last one, but I do appreciate the time and the opportunity to share our story. I'm really excited to see what happens, and I hope that in future renditions of this conference that we can go back and share even more success stories. We cannot do it alone. It's not just ProMedica's journey, but if we're really going to make an impact in our communities, we collectively need to work together to address the inequities. So thank you very much.
So Linda, thank you for sharing ProMedica's journey with the audience today. So I invite you to put any questions that you might have for our panelists on the cards on your table. I do want to thank those who have already submitted questions. In particular, I appreciate your penmanship. Very easy to read. Sometimes, it can be challenging to read somebody's handwriting, but the questions we've got here are all very well articulated and easy to read. So with that, let me start off with Dr. Chisholm. We have a question for you. This week on NPR, there was a piece on effective practices for building good rapport and motivating healthier outcomes. The simple takeaway for doctors was to ask the patient about their work or family. Can you comment?
Sure. I think that is a great finding. I missed that story, so I'll have to go back and catch it. But I believe it for two primary reasons. One is because it creates the impression that you care about something other than the check boxes that you're going through on the EMR when you're doing their history. And that creates a rapport that can reduce social distance and open up conversations. And the second thing, when I say open up conversations, is really important, because sometimes people will tell you stuff in those sort of how's things at work question that they don't tell you when you say, how are you feeling? Because if you say, how are things at work? And you say, oh, I missed a couple of days because of my knee. Oh, you didn't mention your knee. What's going on with your knee? And so you're able to get to the health conversation through things that they may be more comfortable asking or answering. So you're able to do a more engaged conversation. So it makes perfect sense that would be a great way to get better information and better relationship.
Thank you. Next question is for Suzanne. Staff often perceive the data collection task as another documentation burden. How do you suggest addressing this feeling?
Thank you. So I think that as we are working with our staff, that we need to help them to understand the importance of those questions. Some of the questions are just regulatory. We have to ask them anyway. But I still think that they need to understand the importance of it. So when we're doing that training that we're providing for them, give them true scenarios of how that information was used and then how it impacted the care of the patients.
Thank you. Next question was for Linda. With so many pressing social determinants of health issues in our catchment area within our organization, can you recommend a way to choose which is the best one to address first?
That's a very good question. As I said, we started with hunger. We are casting a wide net using the 10 domain screener question. But what we're learning is we are doing some data analytics and predictive analytics around the public reported data and our outcomes on screening. Likely we'll be honing in on a few of those zip codes of greatest need, and I think that's the big thing. Look at those zip codes where there's greatest need. Use your population data to really drive that. Just thinking about our outcomes after 2 years of screening, focusing on food insecurity, financial strain, and behavioral health would probably be where I would recommend you start. But it's really taking that data, looking at your data, and setting up a plan to address it.
Thank you. Dr. Chisholm, what is the typical required educational background of a community health worker?
Okay, first of all, I'm going to answer Linda's question too, because you don't give me the mic. But one way to prioritize things when you have a great long list is, what does the community care about most? Ask the community, where do you want us to start? Because that is where you're going to get the most buy-in, the most support, the most investment, if you start where they feel like they need you, even more than where the data may necessarily drive you. So
Good point.
Add that. In terms of community health worker, it generally depends. You've seen one program, but for the most part, it's a high school diploma. This is not a medical professional. It's generally a high school diploma and a training course. So the State Board of Nursing has a community health worker certification program that can train anybody with a high school diploma to do the work of a community health worker. The biggest credential that you need as a community health worker is being perceived as a true member of the community where you're working. So whether you've lived in that community, you grew up in that community, you speak the language of that community, you are culturally attuned to that community, you have experienced the health issues that community is helping, that's the skill set that we build on more than the academic skill set for a community health worker.
Thank you. Linda, what resources, solutions do you connect patients, employees, or patients or employees with if they have a positive screening for financial strains, behavioral health, food insecurities, et cetera? And as a sort of a follow-up to that, what is your sustainability plan?
Very good questions. Our community care team has developed a resource guide by county, organized by each of the 10 domains that we're screening for. We have social workers, RNs, and community health workers who utilize that resource guide on a daily basis, just depending on the patient's need. If the patient's screening positive, we'll connect for food insecurity, not only connecting them with the food clinic, but our local community shelters and community feeding sites, a lot of faith-based organizations that provide that in our community. Our Financial Opportunity Center and financial coaching. It's really been, we are very fortunate to have the social workers who used to be in our home health division stepped up to take on this role to connect our community members. And so they have a lot of great relationships with our community-based organizations. What was the second question? I'm sorry.
What is your sustainability plan?
That is a very good question. We're in the process of, we developed the clinical integration team, our community care team, to get it launched and off the ground, but it's always been our vision that the screening needs to be owned by operations. So we're in the process of moving some of the screening into our operations, both on the provider side and our ambulatory space, as well as our acute care space. We're moving some of the onus and to our human resource operations through our employee assistance program. Our employees have been very receptive to the connections, the compassion that is felt by our employees because we're asking the questions and then helping them connect. ProMedica made a bold move a few years back to move up our starting wage for any frontline worker to $11.70. And so we are recognizing the need that our own employees need to make a healthy living to be able to provide for their families. But the sustainability will continue to have our strong clinical connection, but our screening will move to our operations. We are planning expansion across our emergency room and acute care in fourth quarter of this year, so I'm anxious to see how that screening turns out. But we know that we cannot continue to add resources to our community care team, but rather create a model and a safety net and the processes outlined to connect the patients.
Thank you. Dr. Chisholm, where do you think is the greatest opportunities for hospitals and health systems to reallocate resources to move the needle on inequalities?
You know, I think that the reality is that even though we keep putting up this slide that says healthcare is 20% of the, pie in terms of factors that influence health and health equity, the reality is that that 20% is one of the richest 20%, one of the richest slices in that pie. So a lot of money flows through the healthcare system. A lot of resources other than money in terms of community goodwill and property and space and all those other things flow through the healthcare system. And so it's really the role of the healthcare system to do the best job they can providing the most equitable care to every patient who walks in their door. That's number one, top of the list. Once you, along with doing that, is figuring out how do you do the best job you can as a healthcare system in providing prevention to keep people from needing acute care. And how do you do that in a way that is culturally appropriate? And then third, how do you engage within the community as a facilitator, a convener, an investor, a bundler to help pull together all the resources in the community, because we can't do it alone. And legally, we can't spend certain dollars in certain ways because Medicaid doesn't let us. So the reality is, or other payers don't let us, or whatever. But it's really about the healthcare system figuring out how to be part of the landscape of health and well-being, not just clinical care. And so it's not just about moving money, it's really about mission.
Thank you. And Dr. Chisholm, another question here. Is there data for reasons why whites do not want to go to underserved areas? And how do we address this, or what resources can we use in order to address this issue?
So there's a couple of hypotheses that are data-driven. One is that minority physicians are more likely to go into primary care specialties. So pediatrics, family medicine, OBGYN, things that happen everywhere. Whereas you have a higher percentage of white graduates going into subspecialty care that ends up being situated in academic medical centers that are in highly served areas. So part of it is just the distribution associated with the specialty choice. Part of it is a personal mission-driven statement that a lot of young African Americans, Hispanics feel required to provide care to the communities that they come from. And it is sort of, you know, my community lifted me up and put me here, and I need to go back there and provide that service. And so to that extent, that also drives where people practice. There's been a lot of policy things that have tried to balance some of that out, you know, loan repayment programs for people who serve in underserved areas, payment differentials for people who are going to work in those areas because it's hard to make money in places where there aren't a lot of patients and the patients are really sick. We don't have an answer yet, but I think that to the extent we can create incentives that balance the I got to pay off $300,000 in loans versus I want to make a difference in the world, we'll be better off.
All righty, thank you. And the final question for today, I'm going to ask Suzanne. I know that the theme of the past 3 days at the meeting has been disruption. And in your work across the state with working with organizations as part of HIIN, what characteristics have you noticed amongst those organizations that are positively dealing with the disruption that's going on in healthcare today?
I think that they take it basically from a basic level, and they start looking at their information, and they're open to look at different ways of doing things, and they pull in those different people that will help them, or entities that will help them to look at that in a different way. And one of those is truly the patient and the family, because the patient and the family, as Dr. Chisholm mentioned a few minutes ago, they're going to tell you those things that are important. And so they're able to focus and prioritize and take those and not become overwhelmed with the great big picture, but set those priorities so that they can build on that and move forward.
So thank you. And for those of you that remain, if we could just give a nice round of applause for our three panelists today.
On behalf of OHA, I'd like to thank all of you for joining us today. This does conclude our program in 2019. We wish you a very safe trip back home. Thank you for being with us this afternoon. I think it was a phenomenal day for all of us, but it really is because of your participation. So we hope to see you soon in any of our events, but particularly again next year for our 13th Annual Quality Summit. So safe travels, everyone.